Headache, one of the most common symptoms, but not all headaches are same. So let's study about headache today. Welcome to my page, White Coat Diaries, where we simplify medicine one topic at a time. There are two types of headache, primary headache and secondary headache. In primary headache, there is no structural cause. We have migraine, tension type headache, cluster headache, trigeminal autonomic cephalgias. While in secondary headache, there is some underlying cause which can be due to infection, tumor, vascular lesion, raised ICP, drugs, etc. So let's learn the key points of each headache. Migraine is a neurovascular disease caused by neurogenic inflammation. Patient present with unilateral, episodic, severe pulsating or throbbing pain. There can be presence or absence of aura, visual or scintillating scotoma. Also, there can be associative features like nausea, photophobia, phonophobia. Triggers of migraine can be stress, glare, exposure to bright light, lack of sleep, caffeine, cheese, alcohol, etc. So, how do we treat it? We can give triptans, NSAIDs, CGRP antagonists like telcacipant, and for the prophylaxis, we can give propranolol, amitriptyline, topiramate, valproate, etc. Moving on to the tension type headache. It's the most common type. Emotions, anxiety, and muscular spasm are the common precipitants. So, what is the clinical picture? Patient presents with bilateral band-like discomfort, dull aching pain, and is not aggravated by activity, and no nausea, vomiting present. Pain is not noticeable when the patient is occupied. So, for the treatment, we can give NSAIDs, analgesics for the acute pain, and if the pain is chronic, that is more than 15 times a month, we can go for amitriptyline. So, moving on to TACs, it includes cluster headache, paroxysmal hemicrania, SUNCT, hemicrania continua. In cluster headache, there is trigeminal autonomic reflex activation. Male to female ratio is 5:1. So the pain happens in the same time daily and in clusters, weeks to months. Patient complains of unilateral, orbital, or supraorbital or temporal region pain. Pain is boring type or excruciating type. Also, there are autonomic features like lacrimation, rhinorrhea, ptosis present with it. So what is the treatment? We give 100% oxygen inhalation and subcutaneous sumatriptan. For the prophylaxis, verapamil is a drug of choice. And we also give short course of steroids for bridging. Coming to paroxysmal hemicrania, there is female predominance, more than 5 episodes per day, with unilateral, orbital, or temporal pain. Autonomic features are same as cluster headache. What is the pathognomic feature? There is complete response to indomethacin. So for the treatment and for the diagnosis, we can give indomethacin. SUNCT and SUNA. So in SUNCT, the episode is very brief. There is stabbing, electric shock-like pain in periorbital area. Autonomic features like conjunctival injections plus tearing is present, and there is no response to indomethacin. So for the treatment, we give lamotrigine, topiramate, IV lidocaine for severe attacks. Whereas in SUNA, E stands for autonomic symptoms. Here, C and T stands for conjunctival injections and tearing. It is same as